Welcome back to the course on nutrition and planetary health, presented by the Physicians Association for Nutrition and PANCO. This course provides an evidence-based foundation for how dietary patterns influence both human health and planetary health, and how this knowledge can be applied in clinical practice to promote healthy and sustainable diets. Let's continue with Module 1 on the health impact of diet. Let's get started with Lesson 1.2, Evidence on Diet and Health. Before you begin this lesson, please answer the following question. This ungraded question is designed to get you thinking. If you are unsure, take your best guess. Which of the following contributes substantially to global cardiovascular disease burden? According to the Global Burden of Disease Study 2023, A. Excess intake of processed meat, B. Excess intake of sodium, C. Low intake of whole grains, D. All of the above? The correct answer is D. All of the above. Many clinicians may intuitively focus on excess, such as too much sugar, too much fat, too much salt. But global analyses consistently show that insufficient intake of protective foods, such as whole grains, fruits, and legumes, also contributes substantially to diet-related disease burden. Before we look at the evidence on food and its health impacts, let's briefly examine how this evidence is generated. Ideally, evidence on the effects of specific foods, nutrients, and overall diets on major health outcomes would come from large, long-term, randomized trials with disease and functional endpoints in representative populations worldwide. In reality, this type of evidence is scarce. Such trials require many thousands of participants, several years or even decades of follow-up, and sustained high adherence to assigned diets. These requirements are often not feasible and, in some contexts, not ethical. Trials that are smaller, shorter, or have low adherence can also yield misleading, null, or negative results. Because of this, nutrition science often relies on a combination of evidence types. Researchers use established methods, such as the Bradford-Hill criteria, to assess whether observed associations are likely to be causal. In practice, stronger confidence usually comes from reproducible evidence from prospective epidemiological studies, combined with randomized trials that test intermediate risk factors such as blood pressure or LDL cholesterol, while carefully controlling confounding. A practical rule for this lesson is to focus more on the direction and consistency of evidence across outcomes than on standalone estimates. Also, keep in mind three common features of diet evidence. First, relative risks are not the same as absolute risks. A 10 to 20% relative change can matter substantially at the population scale, but the absolute impact depends on baseline risk. Second, substitution matters. Replacing one food with another is often the real-world question. Third, effects differ by context. Background diet, food processing, and overall dietary pattern can modify associations. Now, let's apply this by reviewing the evidence-based summary in a beginner-friendly way. While the wider evidence includes a large body of studies and meta-analyses, this lesson uses selected examples to show where the evidence is consistent and where it is more mixed. Let's consider dietary fiber. Evidence is consistently favorable for higher fiber intake across major outcomes. In a major synthesis of carbohydrate quality and health, higher fiber intake was associated with lower incidence of coronary heart disease, stroke, type 2 diabetes, and colorectal cancer, and lower all-cause and cardiovascular mortality. Trials included in the same body of work showed improvements in intermediate markers such as body weight, systolic blood pressure, and total cholesterol. Now let's look at whole grains. Evidence is also favorable for higher whole grain intake across major outcomes. Dose-response meta-analysis of prospective cohorts found that higher whole grain intake was associated with lower risk of cardiovascular disease, cancer, and all-cause mortality. More recent dose-response synthesis supports lower rates of cardiovascular events and mortality with higher whole grain intake compared with refined grain intake. Randomized trials also show that whole grain intake can improve blood lipid profiles, supporting its plausibility. A simple clinical message is that higher intakes of fiber and whole grains have consistently been linked to better health outcomes. Let's talk about fruits and vegetables. Large syntheses consistently associate higher fruit and vegetable intake with lower cardiovascular risk and lower mortality. A dose-response meta-analysis of prospective studies reported lower risk of cardiovascular disease, total cancer, and all-cause mortality with higher fruit and vegetable intake. A large meta-analysis and cohort study found associations with lower mortality, with the strongest marginal benefits often observed when moving from very low intake to moderate intake. A practical takeaway is that fruit and vegetables are consistently linked to lower cardiometabolic risk, and the greatest gains often occur among those with low baseline intake. Here, let's discuss nuts, seeds, and legumes. These foods are often markers of plant-rich dietary patterns. Reviews and meta-analyses show nut intake is associated with improvements in blood lipids and lipoproteins, supporting cardiovascular plausibility. In the prospective urban-rural epidemiology study, higher nut intake was associated with favorable risk factor profiles and outcomes across diverse countries, although interpretation remains subject to confounding and contextual factors. Legume intake was associated with lower mortality in a dose-response meta-analysis of prospective studies. A practical takeaway is that legumes, nuts, and seeds are valuable components of plant-rich dietary patterns associated with favorable long-term health outcomes. Now, let's talk about red meat and processed meat. Evidence linking red and processed meat consumption with health outcomes has been examined in large prospective cohort studies and meta-analyses. Processed meat shows the most consistent associations with adverse health outcomes, while higher unprocessed red meat intake is also associated with increased risk of several chronic diseases, particularly type 2 diabetes and colorectal cancer. A large meta-analysis, including nearly 2 million participants across 20 countries, found that each additional 50 grams per day of processed meat was associated with a 15% higher risk of type 2 diabetes, while each additional 100 grams per day of unprocessed red meat was associated with a 10% higher risk. Evidence syntheses also conclude that processed meat increases colorectal cancer risk, and that higher red meat intake increases colorectal cancer risk. Therefore, for colorectal cancer, authoritative synthesis reports continue to support limiting processed meat and moderating red meat intake, based on the totality of evidence. Umbrella reviews similarly report consistent associations between processed meat intake and cardiometabolic disease, with less strong but still concerning associations for unprocessed red meat, compared with other animal source foods such as fish, poultry, eggs, or dairy. Processed meat shows less favorable health associations, compared with plant-based protein sources such as legumes, nuts, and whole grains. Both processed meat and unprocessed red meat are generally associated with less favorable long-term health outcomes. Overall, evidence indicates that processed meat and red meat have unfavorable health associations, while dietary patterns that emphasize whole plant foods and plant-based protein sources tend to show consistent associations with improved long-term health outcomes. Let's consider dairy foods now. Evidence on dairy consumption and health outcomes is more heterogeneous than for many plant foods, and findings vary by type of dairy product, background diet, and substitution patterns. Prospective cohort studies and meta-analyses generally find that total dairy intake is neutral or modestly favorable for some cardiometabolic outcomes. A meta-analysis reported that higher dairy intake was associated with lower risk of stroke and hypertension, while associations with coronary heart disease and overall mortality were largely neutral. Dairy foods provide nutrients such as calcium, potassium, and bioactive peptides, which may influence blood pressure and vascular function. Evidence from large multi-country cohorts has also suggested lower cardiovascular disease and mortality risk with moderate dairy intake in some populations. However, when compared with whole plant foods such as legumes, nuts, and whole grains, plant-based foods generally show more consistent associations with lower cardiometabolic risk and mortality in large cohort analyses. For clinicians, a practical interpretation of this evidence is that moderate dairy intake could fit within healthy dietary patterns, but diets richer in whole plant foods tend to show stronger and more consistent associations with improved health outcomes. Let's now look at eggs. Egg consumption has been widely studied in relation to cardiovascular disease and metabolic outcomes. A meta-analysis of prospective cohort studies reported that moderate egg consumption, around 1 egg per day, was not associated with increased cardiovascular disease risk in the general population. More recent large cohort analyses similarly report largely neutral associations with cardiovascular outcomes, although results may vary in populations with diabetes. Eggs provide high-quality protein and micronutrients, including vitamin B12, choline, and selenium. However, plant-based protein sources such as legumes, nuts, and soy foods are generally associated with more favorable cardiometabolic profiles and lower disease risk in cohort studies. A practical takeaway from this evidence is that eggs could be included in balanced diets in moderation. However, diets relying more heavily on plant protein sources tend to show more favorable long-term health associations. Now coming to poultry. When compared with red and processed meat, poultry intake generally shows neutral associations with cardiometabolic disease risk in prospective cohort studies. Meta-analyses report no clear association between poultry intake and increased cardiovascular disease or mortality, particularly when poultry replaces red or processed meat in the diet. Poultry provides high-quality protein and micronutrients, and typically contains less saturated fat than many red meats. However, when compared with plant-based protein sources such as legumes and nuts, plant foods tend to show more consistent associations with lower cardiometabolic risk and mortality in large cohort analyses. For clinical interpretation, this evidence suggests that poultry could be considered a moderate animal source protein option, particularly when replacing processed meat. However, plant protein sources generally show stronger associations with improved health outcomes. Now let's consider fish and seafood. Evidence is generally favorable for fish consumption, particularly in relation to cardiovascular disease. Meta-analyses of prospective cohort studies consistently report that higher fish intake is associated with lower risk of coronary heart disease and cardiovascular mortality. Randomized trials of marine omega-3 fatty acids also demonstrate modest improvements in cardiovascular risk markers, supporting biological plausibility. Fish provides nutrients including long-chain omega-3 fatty acids, iodine, vitamin D, and high-quality protein, which may contribute to cardiometabolic benefits. However, plant-based sources of unsaturated fats, such as nuts, seeds, and vegetable oils, are also associated with strong reductions in cardiometabolic risk in observational studies and dietary pattern analyses. This evidence suggests that moderate fish intake is associated with favorable cardiovascular outcomes, while diets rich in whole plant foods and unsaturated plant fats show consistently strong associations with improved long-term health outcomes. Let's now talk about dietary fats, which includes trans fat, saturated fat, and unsaturated fat. Trans fats have strong evidence of harm for cardiovascular disease and should be minimized. WHO guidance continues to recommend limiting saturated fat and trans fat intake at the population level. Evidence synthesis across trials supports that specific foods and dietary patterns can meaningfully lower LDL cholesterol, which is clinically relevant for atherosclerotic risk. In practice, what often matters most is replacement. Replacing trans fats and some saturated fats with unsaturated fats tends to move risk markers in a favorable direction. When discussing sugar-sweetened beverages and added sugars, the evidence is consistent that higher sugar-sweetened beverage intake is associated with a higher risk of adverse cardiometabolic outcomes. A dose-response meta-analysis reported associations between sugar-sweetened beverage intake and higher risk of obesity, type 2 diabetes, hypertension, and all-cause mortality. Systematic reviews of trials and cohorts support that higher sugar intake contributes to weight gain and adverse cardiometabolic risk markers. WHO has long recommended limiting free sugar intake for health. When discussing sodium, evidence shows that it is clinically important because the pathway linking it to blood pressure is well established. In a study using multiple 24-hour urine collections, Each additional 1,000 mg/day sodium excretion was associated with an 18% higher cardiovascular risk. A clear clinical takeaway is that reducing sodium is a direct dietary strategy for lowering blood pressure risk at scale. Let's now consider ultra-processed foods. While evidence on ultra-processed foods is accumulating rapidly, more nuance on classification, interpretation, and language is required. An umbrella review of epidemiological meta-analyses reported that higher ultra-processed food exposure was associated with increased risk of several adverse outcomes, including cardiometabolic outcomes and mortality. It also rated much of the certainty as low or very low, with some outcomes reaching moderate certainty. There is ongoing debate about classification and interpretation, including concerns about treating all ultra-processed foods as identical exposures. A balanced clinical message should highlight that diets dominated by ultra-processed foods tend to be associated with poorer health outcomes. But this is a broad and varied category, and the strength of the evidence varies across outcomes. Finally, let's quickly look at the evidence on plant-rich dietary patterns as a whole. A systematic review and meta-analysis found plant-rich dietary patterns associated with lower risks of type 2 diabetes, cardiovascular disease, cancer, and mortality. A key nuance is in the definition. Plant-rich can mean very different things depending on whether diets are rich in whole plant foods or dominated by refined carbohydrates and sugary foods. A simple way to communicate this clinically would be that the quality of plant foods matters most. Now, let's put this evidence into practice as a clinician-friendly summary. Rather than thinking in terms of good versus bad foods, it is often more useful to group dietary factors into foods to encourage, foods to limit, and foods where moderation and context matter. Foods and patterns more consistently associated with a lower risk of disease or mortality include high fiber and whole grains, fruits and vegetables, legumes, nuts, seeds, and generally higher quality plant-based patterns. Foods generally associated with favorable or neutral outcomes when consumed in moderation include fish and seafood, dairy foods, eggs, and poultry. Foods more consistently associated with higher risk of disease or mortality include processed meats, higher red meat intake, sugar-sweetened beverages and high added sugar intake, excess sodium and trans fats. Now, let's take a moment to reflect how this evidence can be translated into clinical judgment. Clinicians do not need to memorize every hazard ratio. A more practical skill is knowing how to interpret certainty. This requires reflecting on the evidence. Is the evidence consistent across studies and populations? Are there dose-response or plausible substitution effects? Do trials show intermediate changes in the expected direction? Is the claim stable across time, or still emerging? That is how we avoid both extremes, treating nutrition as too uncertain to discuss or certain enough to oversimplify. Before we wrap up this lesson, let's look at the key takeaways to recap what we learned. First, diet influences the risk of major non-communicable diseases, including cardiovascular disease, type 2 diabetes, and some cancers. Second, evidence on diet and health comes from multiple complementary sources, including prospective cohort studies, randomized trials on intermediate risk factors, and systematic reviews. Third, across many studies, diets rich in whole plant foods such as whole grains, fruits, vegetables, legumes, and nuts are consistently associated with lower disease risk and mortality. Fourth, some animal source foods, including fish, dairy, eggs, and poultry, generally show neutral or favorable associations when consumed in moderation. Fifth, higher intake of processed meat, excess sodium, sugar-sweetened beverages, and trans fats is consistently associated with higher risk of adverse health outcomes. Sixth, interpreting nutrition evidence requires looking at patterns of evidence across studies, not relying on single results. Before you move to the next lesson, let's assess your learning through a quick question. Based on what you learned in this lesson, answer the following question. Which statement best reflects the overall evidence on diet and health? A. Nutrition evidence is too inconsistent to guide practice. B. Evidence is strongest when cohorts and trials point in the same direction. C. Only randomized controlled trials are useful for dietary guidance. D. Single nutrients matter more than overall dietary patterns. The correct answer is B. Evidence is strongest when cohorts and trials point in the same direction. The practical implication is measured confidence. Focus on the stable core of evidence. Communicate uncertainty where it exists, and prioritize achievable shifts in overall dietary patterns. In this lesson, we reviewed evidence linking individual foods and dietary factors to health outcomes. In the next lessons, we will examine dietary patterns, which consider how foods are typically consumed together. This matters because people do not eat single nutrients or foods in isolation. We will explore 3 well-studied examples of healthy dietary patterns whose components align with the evidence discussed in this lesson. First, the Planetary health diet. Second, the Mediterranean diet. And third, the DASH diet. These examples illustrate how combinations of foods such as whole grains, fruits, vegetables, legumes, nuts, and moderate amounts of animal source foods can form dietary patterns associated with improved health outcomes. We would value your feedback. Please scan the QR code on screen to share your thoughts on the course content and help us improve this learning resource. Thank you for watching this lesson. This is the course on nutrition and planetary health, developed and presented by the Physicians Association for Nutrition and Panko. You can now move on to the next lesson.